Hello, everyone. My name is Chatterjee, and to briefly introduce myself, I am a graduate neuroscience student and researcher in the Kolber Lab at the University of Texas at Dallas, mentored by Dr. Ben Kolber. And I am also a board certified mental health peer specialist supporting people through my one-on-one and group capacity practice. I'm also the founder and facilitator of the Cancer Thriver Collective, a global mental health peer support group serving cancer survivors worldwide. And today I'm here to talk to you in short about MDMA and OCD, more specifically exploring the potential effects of MDMA-assisted therapy for PTSD on comorbid OCD. So if you're here right now watching this, you might already know something about psychedelic renaissance, particularly psychedelics' novel roles in mental health treatment being explored and discovered right now. In particular, MDMA-assisted therapy for PTSD is such a breakthrough, incredible therapy right now. FDA phase 3 clinical trial results are incredibly promising with incredible results. And it's just one of the best mental health breakthrough treatments in decades. But what if I were to tell you that a significant part of the population of PTSD patients could potentially be harmed by this treatment? I say that because of the phenomenon of comorbid PTSD and OCD. So in the general population, the incidence of OCD is around 1 to 3% that we know of, but surprisingly, in the PTSD population, the comorbid incidence is 30%. So about 30% or more of patients with PTSD also have OCD. Now, why on earth do I know about this question? Why does this matter to me? A little something called me search, because I am someone with comorbid PTSD and OCD, and I'm going to share a little bit about how I got to the place I am right now with this question. So I initially started mental health treatment at 13 years old for some general mental health conditions, but I was still dysfunctional after this for 8+ years. And finally, I was diagnosed in 2018 with OCD at 21 years old. I began treatment with a general psychologist, but as we'll talk about more later, I ended up receiving the wrong treatment for it. So then 1 year later, I was diagnosed with cancer at 22, and cancer was the catalyst for me to finally start getting treatment for the PTSD I had had for about 18 years at that point. So I finally started PTSD treatment with a PTSD specialist. And in going through that for about a year, I came to the realization that OCD for me was still debilitating as much as I didn't want it to be. And OCD was interfering with my PTSD treatment being able to work. So I consulted Dr. Google very thoroughly and started looking for if I was missing something about OCD treatment. And I realized that there's actually only one OCD treatment that works, which is called exposure and response prevention therapy, which I had not been receiving. So I then proceeded to receive that starting in 2021 with an OCD trained specialist. And I had the quick and hard realization that when done correctly, OCD treatment actually worsens PTSD. And conversely, when PTSD treatment's done correctly, it worsens OCD. So bringing this all together to the present today with the me search as a neuroscience researcher and as a mental health peer specialist and combining all my disciplines, I am sitting here wondering, how would MDMA assisted therapy for PTSD affect comorbid OCD in the 30% of people who have comorbid PTSD and OCD like me? So in exploring this research question of what are some potential effects of MDMA-assisted therapy for PTSD and comorbid OCD, we're going to talk about 3 things today. First, I will overview OCD, PTSD, and their comorbid nature. I'll then talk about considering comorbid OCD in the conduction of MDMA-assisted therapy. And finally, we'll talk about some of MDMA's mechanistic underpinnings related to OCD neurobiology and treatment. So let's start with a quick overview of OCD, PTSD, and their comorbid nature. So when you may think about OCD, as many people do, you might think about someone being super obsessed with cleaning and organization and perfection. You might have heard people say the term, I'm so OCD about, insert in the blank, whatever they think they're OCD about. And the worst part, sometimes people say, aren't we all a little OCD? The truth of the matter is, though, OCD is not an adjective. It is not something that describes a desire to be a certain way or to do a certain thing. And to top it all off, as someone who has OCD, I am sharing with you my literal desk and what it looks like over here. And it is not organized, it is not clean. And I have OCD and I'm not obsessed with that. So that's just a funny way of saying that that is not the misrepresentation of OCD is not what OCD actually is. So what is OCD? It is in sum from the DSM, a compulsion and obsession combination. So obsessions are defined as recurrent and persistent thoughts, urges, or images that are experienced as intrusive and unwanted, and that in most individuals cause marked distress or anxiety. The thoughts, impulses, or images are not simply excessive worries about real life problems. And then you add in the compulsions, which are repetitive behaviors or mental acts that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. And OCD is a debilitating disorder. It is not a choice. And if you had to sum OCD up into what it is basically a doubting disorder. OCD causes the sufferer to doubt everything. And so obsessions are distressful and they're seeking to certainty, and compulsions are done in an attempt to create certainty, but they fail. So anything can become an obsession. It's not just about cleaning or about perfection or about color coding. It can literally span any topic, and it does not spare or discriminate against any topic. And then subsequently, anything can become a compulsion. And I really wanted to point out mental compulsions because they're going to play a role in PTSD, as we'll talk about later. So people generally think about compulsions as, again, hand washing or wiping things, checking things, redoing things, but actually compulsions can be far more pervasive and discrete. So there's so many things such as rumination and mental review, neutralizing thoughts, compulsive praying, reassurance seeking. There's just so many internal compulsions that you may not be aware of. And they may be very similar to PTSD symptoms. Additionally, OCD is often misdiagnosed and mistreated. So as I said before, I had received the incorrect treatment for OCD, as many people do, and the actual treatment for OCD is exposure and response prevention therapy. Also, on average, it takes about 14 to 17 years for someone to receive correct treatment for OCD because of this misrepresentation and misunderstanding of OCD. People don't know that they have it. They don't realize that they might need help and they may not seek help. And sometimes clinicians also may not understand OCD. They're not trained on it properly, and they therefore don't know how to treat it. I bring up this misunderstanding because of the harmful downstream effects of potentially not being able to seek help or identify what is going on within someone. So now let's quickly talk about what post-traumatic stress disorder, or PTSD, is. The DSM defines PTSD as a psychiatric disorder that may occur in people who have experienced or witnessed a traumatic event and then are plagued with disturbing thoughts and feelings related to their experience that last long after the traumatic event has ended. PTSD symptoms are very similar to OCD symptoms and behaviors. So they generally fall into these four clusters of symptoms, such as intrusion, avoidance, alterations in cognition and mood, and alterations in arousal and reaction. And all four of these things also occur in OCD, which is something that will play a huge role in what we're talking about today. Additionally, PTSD treatments are actually contraindicated for OCD. This means that not only are PTSD treatments not helpful to OCD, but they are actually harmful to OCD and make it worse. So things like traditional cognitive behavioral therapy, exposure therapy, psychodynamic therapy, and EMDR therapy are all harmful to OCD. And this is really important to note because there are many other diseases, psychiatric and otherwise, that are comorbid with PTSD, but generally treatments are helpful to both those diseases, or they at least don't harm those comorbid conditions, such as major depressive disorder. However, in this situation, these treatments harm the comorbid condition, which is a huge role in what we're talking about today. Another aspect of all of this is that oftentimes OCD and PTSD can be functionally dynamically related, such that the symptomology can be similar in both and can be tied to both the OCD and PTSD. For example, someone with OCD's obsessions can be actually rooted in traumatic experiences and beliefs that actually happened to them. And then compulsions can be used to cope with the traumatic stress from PTSD in ways such as thought neutralization or avoidance. And it can be very difficult for untrained clinicians to parse this out. Also, people with comorbid PTSD and OCD are shown to experience more severe symptomology of both illnesses than patients with either just PTSD or OCD. So now that we've talked about those three facets of OCD, PTSD, and their comorbid nature, let's now talk about maybe considering comorbid OCD in the conduction of MDMA-assisted therapy as it's done right now. So we will be talking about current OCD screening practices and the current OCD PTSD treatment conduction. So I will start by saying that the place that I sourced all of my information from is the most famous phase 3 FDA clinical trial for MDMA-assisted therapy. And I looked through all of their procedures and the way that is conducted to then make this assessment. So currently, in terms of screening for OCD in the patient population being treated in MDMA-assisted therapy, I found that there are no OCD screening tests. There are several tests that are conducted to see if people happen to have other conditions, but the test used for OCD, called the Yale-Brown Obsessive Compulsive Scale, is not used to screen out patients, which is a red flag to me. Additionally, there is in the exclusion criteria where the clinical trial chooses who can or cannot enter into MDMA-assisted therapy, there are several different clusters of conditions that are excluded from this trial, but OCD or obsessive compulsive related disorders are not one of those. So since the clinical trial does not explicitly exclude OCD or obsessive compulsive related disorders, and there's a 30% comorbidity rate, just think about how many people with comorbid OCD could be making it into this MDMA-assisted therapy situation without knowing it. And to top it all off, currently in MDMA-assisted therapy, in the assisted therapy part, several of the therapies that are conducted, the psychotherapies, are all contraindicated for OCD. So now we have a situation where people with OCD are potentially making it through into this situation, and they're receiving treatments that are harmful to their OCD. Now, to come into the MDMA side of things, we're going to talk about MDMA's mechanistic underpinnings related to OCD neurobiology and treatment. And we'll talk about specifically OCD and MDMA's potential interactions, and then the phenomenon of reopening critical learning periods with MDMA. So potential MDMA and OCD interactions. OCD's general flagship characteristics that are accepted currently in neurobiology include decreased serotonin, which is a transmitter that regulates your mood, and it's often called your body's natural feel-good chemical. When you have low serotonin, specifically in OCD, it can make patients much more edgy and hyper-aware of their environments than usual and can result in increased OCD behaviors. There's also a marked decrease in dopamine, which is a neurotransmitter that generally regulates movement, memory, and pleasurable reward and motivation. When one might have low dopamine in the context of OCD, it can mean that they have low reward experiences. And because there's no reward, people can compulsively continue to do compulsions to try to alleviate anxiety. And it's important to note that current treatments for OCD, while they're not great in their efficacy, the best things we've found so far are serotonin reuptake inhibitors to increase serotonin and deep rate stimulation in the nucleus accumbens to increase dopamine and therefore increase reward. Now, MDMA has so many properties that I could not possibly talk all about in this talk, but some of the incredible ones that relate to OCD are that, one, they block both the serotonin and dopamine transporters, which means that the function in the brain that vacuums up neurotransmitters is blocked, which helps them release or increase more neurotransmitters and send more messages between neurons that work with serotonin and dopamine. So increased serotonin and dopamine in some. Additionally, MDMA is a serotonin and dopamine receptor agonist, which means that it also activates serotonin and dopamine receptors to release more neurotransmitters. So again, more serotonin and more dopamine. So potentially as a treatment, it can help increase serotonin in OCD patients. It can also help increase dopamine in OCD patients, which is great. It can also potentially be administered far less often than people who have to take daily medications with SSRIs and maybe just have to take MDMA instead a few times a year. It's also arguably much safer than deep brain stimulation because of a lack of electrodes and surgery needed. It's not as invasive. So overall, MDMA might have many more functions that are currently unknown, but overall, it seems to be a great treatment option on a pharmacological level for OCD. However, on a neuropsychopharmacology level, a key aspect of MDMA that's being explored right now is the idea that MDMA reopens social critical learning periods in adult mice. Critical learning periods are basically a hyperplastic state for change. We generally have them as humans throughout life, but they are marked to where they open and then they close. And a goal in neuroscience for a while has been to find a way to reopen this period to potentially harness it for therapeutic use, which MDMA does. And it's great. It also potentially has the effect to last for around 2 months to a year in humans. So what that tells me is that the role of MDMA in MDMA-assisted therapy far exceeds just the trip. And the psychotherapy and integration aspect of MDMA-assisted therapy is crucial because it's not just the administration of MDMA that's making a difference, it's all the therapy that happens after. So the therapy and the therapists are of utmost importance in this entire therapeutic situation. So coming back to the research question of what are the potential effects of MDMA-assisted therapy for PTSD on comorbid OCD, it sounds like MDMA may be pharmacologically great to benefit some OCD neuropathology, but when MDMA reopens critical learning periods, it can greatly amplify the harmful effects of contraindicated and harmful PTSD psychotherapy that is happening in those patients. And like we've already discussed, of this patient population, if 30% of patients happen to have comorbid OCD, that means 30% of patients could potentially be harmed overall by this entire situation. Now, you may be wondering, what about current MDMA-assisted therapy results? Why, if this is true, are 30% of the population not being completely just wrecked by current clinical studies? Well, currently speaking, PTSD treatment is being quantified for just PTSD outcomes, not OCD outcomes. So we're only measuring PTSD. We're not even measuring OCD. And PTSD treatment does work. So in terms of PTSD, it might be working great, but we just don't know what's happening for patients with comorbid OCD. There's no way to actually quantify that in this current paradigm. And oftentimes, again, PTSD treatment makes OCD worse, but where are we measuring it? Additionally, when people go through PTSD treatment, there is compulsive behavior that can come up, which does provide temporary relief and can definitely look like there is some sort of relief, but it's not full, it's not permanent, it's not recovery. And this is especially true in functionally dynamic OCD and PTSD, where symptoms of both are related. And finally, it takes about 14 to 17 years for someone to even receive effective treatment and know they have OCD. So it's very unlikely that in the time that people are being measured post the trial, they're going to realize they have OCD and they've actually been harmed in this situation and then report it to the trial to then report those negative outcomes. So my hopes for future directions through talking about all of this is in the trials, if there's a way to include a way to screen out OCD patients with a Y-box test, that would be absolutely great. Additionally, if people with OCD end up making it into the trials or into MDMA-assisted therapy, if there was a way to train clinicians to identify repetitive and compulsive behaviors and then administer response prevention instead of the treatments that are currently contraindicated for PTSD, that would be so helpful. And then ultimately studying MDMA-assisted therapy for OCD, studying comorbid conditions and exploring what this potent medication and treatment can do for the OCD population. And finally, For me, on my personal journey, I hope to explore the mechanistic underpinnings of MDMA and other psychedelics in preclinical models, elucidating further neurobiology of OCD and studying the overlap of OCD and PTSD circuits, as I'm so passionate about it. Thank you so much for listening. I hope you leave this talk with a better understanding of OCD and a new perspective on comorbid conditions. And thank you so much for your time.